एग्ज़ाम पॉइंट ऑफ व्यू से और एकेडमिक या सकाइट्री के नॉलेज या अच्छा और बुरा सकाइट्रिस्ट होने के लिए दो मुख्तलिफ पैरामीटर्स हैं। ठीक है। सो जब आप एग्ज़ाम देने जाते हैं तो आपको बहुत स्ट्रक्चर्ड और फॉर्मेट होना होता है। उसमें बहुत सारी चीज़ें जो आप लोग एक्सपेक्ट कर रहे होते हैं कि होंगी वो नहीं होती। ठीक है। इसीलिए लोग फिर एग्ज़ाम में ना थोड़ा सा दे फील वेरी स्ट्रेंज कि ओह ये सवाल ये तो इतना इम्पोर्टेंट भी नहीं था, ये आ गया। सो एज अ कैंडिडेट मेरे लिए जो सवाल ज़रूरी हैं कि जी साइकोलॉजी पढ़ लूँ और फिर उसके बाद मैं थ्योरी सारी कवर कर लूँ और बाकी चीज़ें जैसे आप लोग मुझे भी कहते थे कि पर्सनालिटी डिसऑर्डर्स कवर करा दें। अब पर्सनालिटी डिसऑर्डर्स एग्ज़ाम सिचुएशन में आते हैं, ये मैं नहीं कह रहा कि नहीं आते, लेकिन उसमें जो वो आते हैं वो उस तरह से नहीं आते जिस तरह से हम लोग उसको पढ़ने की कोशिश कर रहे होते हैं। सो अनफॉर्चुनेटली यू पीपल हैव टू अंडरस्टैंड कि एग्ज़ाम एक एक प्रोसेस है और उस प्रोसेस में आपकी कामयाबी नाकामी इस बात पे डिपेंडेंट नहीं है कि आप कितने अच्छे सकाइट्रिस्ट हैं। वो बहुत सारे कैंडिडेट्स ऐसे होते हैं जो जिनको सकाइट्री की अलिफ बे भी नहीं पता होती लेकिन वो एग्ज़ाम में पास हो जाते हैं, और बहुत सारे कैंडिडेट्स ऐसे होते हैं जो सकाइट्री में बहुत अच्छे होते हैं और फिर भी उनकी सकाइट्री का एग्ज़ाम पास नहीं होता, विच इज़ अनफॉर्चुनेट। बट एग्ज़ाम एक टेक्निकल प्रोजेक्ट है जिसके लिए आपको टेक्निकली ही चलना है। सो एग्ज़ाम में कौन से टॉपिक्स हैं, टेबल ऑफ स्पेसिफिकेशंस क्या कह रहा है, टेबल ऑफ स्पेसिफिकेशन में कौन कौन से सब्जेक्ट्स कवर हो रहे हैं, वो कैसे पूछे जाने हैं, वो चीज़ ज़रूरी है। आपके लिए ये ज़रूरी नहीं है कि आप अच्छे सकाइट्रिस्ट बने एग्ज़ाम पास करने के लिए। इसकी मिसाल मैं अक्सर अपने सारे जूनियर्स को देता हूँ। मेरे साथ जब मैं FCPS पार्ट 1 का पेपर दे रहा था तो मेरे साथ एक मेरा हाउस अफसर था लॉन्ग टाइम बैक, और उस वक्त वो हाउस अफसर जो है वो मेरे उस्ताद प्रोफेसर मुबशर साहब का बड़ा वो फेवरेट भी था, और उसको इतनी सकाइट्री आती थी कि उसको ऑक्सफोर्ड के आप सफ़ा नंबर से भी पूछ लेना। उस ज़माने में भी जो ऑक्सफोर्ड थी, अब तो खैर ऑक्सफोर्ड भी चेंज हो गई है, कि जी पेज नंबर 291 पे क्या है, तो वो ठक 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 सारी चीज़ें बताता था कि पेज 291 पे क्या लिखा हुआ है, कौन सी थ्योरीज हैं, कौन सी डिस्क्रिप्शन दी गई है, क्या डिसऑर्डर है और उसके बारे में क्या बात की गई है। सो अच्छा, काइंडली अपने माइक्स म्यूट कर दीजिए, थैंक यू। सो बेसिकली कहने का मकसद ये है कि जब भी एग्ज़ाम होता है, और वो बेचारा उसी की कहानी सुना रहा था, डिस्ट्रैक्ट हो गया। सो जब वो एग्ज़ाम देने जाता था तो वो फेल हो जाता था। नाउ दिस वाज अनफॉर्चुनेटली अ बिग प्रॉब्लम कि वो इतना अच्छा, जिसको साइकाइट्री आती थी, उसको साइकोलॉजी आती थी, उसको पैराडाइम्स आते थे, वो हम जैसे लोगों को जो FCPS पार्ट 1 का एग्ज़ाम दे रहे थे, वो हम लोगों को बिल्कुल बिल्कुल मतलब हम उसके आगे ज़ीरो होते थे। सो वो 100 था और हम ज़ीरो थे। उसके बाद मेरा पार्ट 1 भी हो गया, पार्ट 2 भी हो गया। उसने इम्तिहान दिया 1 दफ़ा, 2 दफ़ा, 3 दफ़ा, और वो पास नहीं हो सका, और अनफॉर्चुनेटली ही वेंट टू कम्युनिटी मेडिसिन, और अभी भी शायद कम्युनिटी मेडिसिन में ही हो। दिस इज़ बिन 30 ईयर्स, और मैं साइकाइट्रिस्ट बन गया और साइकाइट्रिस्ट में सारी प्रोग्रेस भी हो गई। सो कहने का मकसद ये है कि एग्ज़ाम पास करना और अच्छा साइकाइट्रिस्ट होना और साइकाइट्री का नॉलेज होना एक डिफरेंट पैरामीटर्स हैं। सो मैं जो आप लोगों को तैयारी करवाना चाहता हूँ, मैं सिर्फ इसलिए तैयारी कराना चाहता हूँ कि मैं अपनी जो भी मेरी नॉलेज है या जो मेरी एक्सपर्टीज़ है वो आप लोगों से इस तरह शेयर करूँ कि आप लोग एग्ज़ाम पास कर लें। ठीक है। उप्स, सॉरी, उप्स, ये डिस्कनेक्ट हो गया, सॉरी। वाई डिस्कनेक्टेड आई डोंट नो, बट अपने अपने माइक म्यूट कर लें, फिर उसके बाद दोबारा शुरू करते हैं। सो टेबल ऑफ स्पेसिफिकेशन भेजने का मकसद आप लोगों को सिर्फ एक है, और वो टेबल ऑफ स्पेसिफिकेशन भेजने का मकसद ये है कि आप लोग वो तैयारी करें जो आप लोगों के लिए एग्ज़ाम में ज़रूरी है। सो एग्ज़ाम का अगर आप टेबल ऑफ स्पेसिफिकेशन देखें तो उसमें स्पेसिफिक टॉपिक्स मेंशन किए गए। अब ये नहीं है कि उस प्रोसेस में सिर्फ वही टॉपिक आएंगे, कुछ और टॉपिक्स भी आ सकते हैं। मसलन उसमें पर्सनालिटी का जिक्र किया हुआ है तो सिर्फ पर्सनालिटी डिसऑर्डर्स नहीं आएंगे, पर्सनालिटी थ्योरीज नहीं आएंगी, पर्सनालिटी की बायोलॉजिकल मैनेजमेंट भी आ सकती है, पर्सनालिटी के बाकी पैरामीटर्स भी आ सकते हैं। सो कुछ भी उसमें कवर कर सकते हैं, लेकिन ब्रॉडली स्पीकिंग देयर आर डेफिनेटली अ सिस्टमैटिक अप्रोच टू अपीयर इन द एग्ज़ाम। और मैं इन एकेडमिक एक्टिविटीज़ के बेसिस पे सिर्फ और सिर्फ ये चाहता हूँ कि आप लोग वो टॉपिक्स मेरे से कवर कर लें जो एग्ज़ाम में कवर होने। अब उसमें एग्ज़ाम में आईएमएम के मॉड्यूल में अगर आप लोग उसको देखें तो उसमें बिहेवियरल साइंसेस के बहुत सारे टॉपिक्स हैं। मसलन एथिक्स है, मोरालिटी है, एटीट्यूड है, एंगर मैनेजमेंट है, स्ट्रेस मैनेजमेंट है, ब्रेकिंग द बैड न्यूज़ है। ये वो सारे टॉपिक हैं जो बहुत इंपॉर्टेंट है आईएमएम के लिए भी और एफसीपीएस पार्ट 2 के लिए भी, लेकिन मैं उनको कवर नहीं कराऊंगा बिकॉज ये वो टॉपिक्स हैं जो आम तौर पे आपके तमाम टीचर्स बिहेवियरल साइंसेस के स्टूडेंट्स को जब पढ़ाने जाते हैं और अगर आप उनके साथ चले जाएं तो ये टॉपिक्स कवर हो जाते हैं। सो आई डोंट हैव टू री इन्वेंट द व्हील और आई डोंट हैव टू गो through the process of teaching you some topics which are probably taught by other people as well. So I want to keep myself focused to the topics which are usually not covered. Usually, I'm not saying they are not covered, but are usually not covered. So I'm picking up the topics according to the exam format which are important for you people. ठीक है? Everybody clear? कोई भी चैट बॉक्स में कुछ लिख दे, मुझे समझ आ जाएगी। राइट? ओके, सो हम दोबारा से शुरू करते हैं जो ओके स्टार्ट शेयरिंग। आई होप आई हैव स्टार्टेड शेयरिंग। क्यों जी, स्क्रीन नजर आनी शुरू हुई?
जी सर।
परफेक्ट, ओके। सो आज का टॉपिक वो टॉपिक है जो चाहे कैंडिडेट्स आर इन एफसीपीएस पार्ट 1, आईएमएम और पार्ट 2, इट इज आस्क्ड एवरीवेयर। सो द सुसाइड असेसमेंट।
देयर इज अ लिटिल प्रॉब्लम कि आपकी स्क्रीन है वो सामने है और जो
प्रेजेंटेशन है वो पीछे है। आ गई। डोंट वरी अबाउट दैट, वो मैं करूँगा।
फेस स्क्रीन है उसके पीछे।
हाँ, मैं वो करेक्ट कर दूँ। अब भी कर लेते हैं करेक्ट। बस ये लो, हो गई। ठीक है, ओके। सो टॉपिक सुसाइड का हर लेवल पे पूछा जाता है। थ्योरी में पूछा जाता है, वाइवे में पूछा जाता है, शॉर्ट केस में भी आ सकता है, लॉन्ग केस में भी आ सकता है। जो आईएमएम के टेबल्स ऑस्की स्टेशंस हैं उनमें भी आ सकता है। सो इट कैन बी आस्क्ड एट एनी पॉइंट। सो दिस इज़ अ वेरी वेरी इंपॉर्टेंट टॉपिक। और जब भी किसी भी पेशेंट को आप देख रहे हो, चाहे वो एंग्जाइटी हो, चाहे वो डिप्रेशन हो, चाहे वो स्किज़ोफ्रीनिया हो, चाहे वो मेजर डिप्रेसिव डिसऑर्डर है, अगर मैं आपको असेस कर रहा हूँ और आपने सुसाइड एग्ज़ाम में किसी भी मॉबिलिटी के लेवल पे नहीं पूछी या सुसाइड असेसमेंट नहीं की, तो मेरे हिसाब से आप अच्छे साइकियाट्रिस्ट नहीं होंगे। सो आई कैन फेल यू ऑन दैट बेसिस। So suicide assessment, suicide risk assessment, suicide related topics are the crucial and important area which needs to be covered in the exam situation. So that is very, very important. So you have to understand that that is important, right? When is the recording ho rahi hai? Okay, so suicide usually is basically a Latin word, means self-murder. So self-murder means apne aap ko, to kill your own self or to harm your own self. Now there are two different topics, suicide and deliberate self-harm. So deliberate self-harm is a different topic and suicide is a different topic. So I will cover some of the things in this presentation about the deliberate self-harm, but most of the situation I will cover just the suicide. So suicide comes from a Latin word meaning self-murder, fatal act that represents the person's wish to die. And suicide is an irrational desire to die. Suicide is a symptom and sign of a serious psychiatric morbidity or major depressive disorder. Sometimes when we give antidepressant medication to depressed person, they will still feel depressed but have more energy and it is during this time many people tend to make suicidal acts. So ये common theme है कि जब भी एंटी डिप्रेशन, ये पैक्सल पे पैरोक्सिटीन पे बहुत एक ज़माने में शोर मचा था कि जी ये सुसाइडल आइडिएशन को बहुत propagate करती थी. Actually it's not like that, that it is actually increasing the suicidal ideation in the patient. Patient is already suicidal, and when you give an antidepressant, they lift up the physical symptoms, gets better earlier, then the psychological symptoms. So the thought process remains suicidal, but you have an energy to do something, and then you do it. So during the first 2 to 3 weeks time period, when you give an antidepressant to a suicidal patient, that you have to be very careful. And that is the reason why we always tell to either to hospitalize the patient, or to make sure that nothing lethal is in with the patient, or the patient is in a very fine and appropriate environment. Okay, can you see me still? Okay, let's go ahead. More definitions. Suicidal ideation, thoughts or act of killing oneself, and does not include the final act of killing oneself. Even the thoughts of having a suicide, a death wish. I usually ask the patient about the death wish. Do you feel like sometimes that you should not be alive? You should just go away, or you should not be in this world? That is also important. Suicidal intent is to have suicide as one's purpose. An intent refers to the aim, purpose, or goal of the behavior. So if I am harboring suicidal intentions, this means that I have the tendency, and I have a purpose, and I have an aim to end up my life, but it's not necessary that I have ever committed the act, or I have ever indulged myself into it. But even the intent is unfortunately complicated, and we should be careful about it, right? And we have to treat the patients who are having the suicidal intent with the same intensity, with same vigor, with same professionalism as we are treating the other patients. Para-suicide. Now the para always means around. जहाँ पे भी लफ्ज़ para आएगा means around. So around the suicide is para. So when you say para, this means that around suicide. So there are multiple things which are happening around the suicide, right? Like patients who injures themselves by self-mutilation usually do not wish to die. Like deliberate self-harm, as I mentioned to you, in borderline personality disorder or other personality problems and other disorders as well, impulse control disorders and other psychiatric morbidity, there is a possibility of deliberate self-harm. When we will cover the deliberate self-harm, I will try to explain to you which are the most common parts where people do deliberately harm themselves. It's not only the arms. Usually we see only the arms. That is another problem. So in exam situation, क्योंकि अब ये बात आ गई तो मैं इसको कवर कर रहा हूँ. अगर कोई पेशेंट आपको deliberate self-harm का in exam situation is presenting to you, it's not actually that you have to see only the arms.
सर आज बहुत ज़्यादा हो गया. I'm sorry मैं आपको इंटरप्ट कर रही हूँ. अगर किसी भी टाइम कॉल ड्रॉप, आज 30 कैंडिडेट्स हो गए, अगर कॉल ड्रॉप हो जाए काइंडली सब दोबारा ज्वाइन कर.
Just let me know. मुझे मैसेज कर दीजिएगा, मैं कर लूँगा. ओके?
ठीक.
और रिकॉर्डिंग रुक जाए तभी बता देना. तभी बता देना. Okay.
ठीक है.
So deliberate self-harm, you don't have to only examine the arms. You have to examine other parts of the body. So the deliberate self-harm is most common in actually perineal area or lower belly or upper chest. It's not only the arms. So you have to examine some other parts as well. Unfortunately, in exam situation, you cannot examine the genitalia of the person or the inner thighs of the person, but you should ask at least, so the examiner should know that these are the common areas of deliberate self-harm. So in deliberate self-harm, when patient tries to cut himself or herself, there is no pain. Rather, they enjoy it. Rather, their pain and anger subsides. There is a different pathology for that. Why that happens, I will come to that when I will cover the topic. Usually, they do not feel pain, do it due to anger and release of tension, having personality disorders, and usually more introverted, neurotic, and hostile people do the deliberate self harm. And unfortunately, it is more common in females than in males. Same goes for the suicide as well. It's more common in females and less common in males, but this with the suicide is more common in males than in the females. So that you have to know the relationship. Now, suicide prediction. So how can I say that this person will definitely commit a suicide? So I have to be prepared for that. And this is what my idea is, that you should be aware of it, how to assess and predict that this person may commit suicide. That's the psychiatric sense that you have to use. And in the exam, you have to prove this, that I feel that this person is suicidal because of this problem. So let's go through that. Suicide prediction refers to the foretelling of whether suicide will or will not occur at some future time, based on the presence or absence of specific number of defined factors within a definable limits of statistical probability. So basically, when you are assessing, you assess the factors which are already there, right? All you have to do is to pick up those factors and make sure that the statistically common factors are asked first and the less common factors are asked less. So if you will ask me, a family history of major depressive disorder, so it is one of the factor contributing to suicide prediction. Suicide risk assessment refers to the establishment of a clinical judgment of risk in the very near future based on the weighing of a very large mass of available clinical detail. Risk assessment carried out in a systematic, disciplined way is more than a guess or intuition. It is reasoned, inductive process and necessary exercise in estimating the probability of over a short period of time. Now, when we say short period of time, this is the exam situation, right? So this is what we mean by this, okay? So you have to understand that when we say suicidal ideation, suicidal risk assessment, or suicide prediction, we intend to mean certain things, very specific things. And it's not just the guess that I feel that this person may commit suicide. No, this is not like that. So you have to be very precise. Why do you feel that this person will commit suicide? There are definitely factors contributing to it. So components of suicide risk assessment. One, appreciate the complexity of suicide, multiple contributing factors. So it's not just only one thing. The major depressive disorder will commit suicide. No, there are multiple factors. Conduct a thorough psychiatric examination, identifying risk factors and protective factors, and distinguishing risk factors which can be modified from these which cannot. So, when we are assessing the suicide risk assessment, when we are doing it, we have to clearly find out the two things separately. One, whether these are the protective factors, and these are again factors which can contribute. And the protective factors, they have to be highlighted in a way that they are modifiable or non-modifiable. So there are protective factors which are modifiable. So if supposedly somebody's family is not very much interested and they don't feel that this person will commit suicide, so this is a modifiable supportive factor of suicide prediction. So you will just try to modify those protective factors which are modifiable, right? I will come to the detailed example once again. Ask directly about the suicide. Now, this is a very big controversy because people, like, if the other day, one of my, again, person who was working in my clinic here in Pakistan, I was doing the clinic and he said to me that I haven't told my mother that she is having a cardiac problem because she will get more upset and she will be, again, losing her heart and probably it won't be good for her. And when they went to see a cardiologist, the cardiologist was absolutely blunt with the patient. And he was able to straight away say to the patient, right, in her face that you have a cardiac problem, this is what the problem is, and this is what is needed. Now, this controversy whether we have to disclose the information to the patient or whether we should not disclose the things to the patient is unfortunately a problem. But to honestly speaking, more scientific data is in favor that we should disclose it to the patient about his illness, about his terminal illness, about the suicide, about the psychiatric morbidity. They should be aware of it. They should be aware of it, and they should be able to decide few things in their life rather than hiding from them just to make sure that they remain comfortable. So we should not tell them. No. So one, asking डायरेक्ट क्वेश्चंस अबाउट द सुसाइड. क्या आपको कभी ऐसा जहन में ख्यालात आते हैं कि ज़िंदगी बेकार हो गई, इसको ख़त्म कर लेना चाहिए? नाउ ये सवाल थोड़ा सा मीठा मीठा है लेकिन इसको मॉडिफाई किया. सो दिस क्वेश्चन इज इम्पोर्टेंट. सो डू यू फील sometimes a thought comes to your mind to end up your life? That is important, right? So you have to ask this question. Ask directly about the suicide. Then you have to assess the level of the risk. Low, moderate, high. Definitely people who are having high risk factors of committing suicide, they should be hospitalized, admitted. So the management strategy changes. To the patients who are having mild kind of or a low kind of intensity of suicidal ideation, there maybe you can utilize the services like you can treat them at home, you can educate the family, can alarm them, but moderate to high level of suicidality, hospitalization is must. So in exam situation, if you assess that this person may be able to commit the suicide and its level is moderate to high, the management plan changes. So the management plan at the top is hospitalize the patient, admit the patient, and then assess him again. So that is very, very important. So you have to make sure that you have to assess that, right? Ask directly about the suicide, assess the level of suicide risk, and also the treatment setting and plan. So hospitalization or no hospitalization. And then documentation is important. Suicide is a multifactorial thing. Psychiatric morbidity or illness is one of the component besides the other. So neurobiology, like family history, strong history of suicidality, major depressive disorder, schizophrenia, substance abuse, they contribute more. Impulsiveness, so the personality disorders, the chances of committing suicide there, comorbid with personality disorder, again, there are more. Hopelessness, major depressive disorder and having hopelessness. Family history, strong contributing factor. Psychodynamics and psychological vulnerability. So like people who are having autism, intellectual disability, low level of IQ, maybe 70, 75 IQ, that is considered to be low. It's in the borderline range, but it is low. So low IQ people. Then suicidal behavior. He attempted suicide in about 10 years once. Now you will say, 10 साल पहले इसने कोशिश की थी. So that's not important. No, that is very, very significant when you are assessing a suicide risk. Life stressors, financial loss, pandemic destroyed the business. There are no money. I have to feed my kids. I have to pay my debts. I have to pay for my mortgages. I have to pay loans which I owe to people. So life stressors are important. Wife is sick. One of the child is having autism. These are important factors. I'm specifically quoting them. Access to weapons. Now, unfortunately, this is a very complicated situation. In Pakistan, people do have access to the weapons. It's the same here as well. People do have access to the weapons. So people can go and buy weapons if they are eligible for it. So you have to show your identity, you have to show your certain parameters, and you can get a hunting rifle. Now, hunting rifle may not be a weapon, considered weapon, because it's used to hunt the ducks or used to hunt other animals, but they can be lethal if they are used in humans. So it is important. Severe medical illnesses. Now, when I say severe medical illness, I don't mean diabetes or hypertension. Well, yes, complicated diabetes, complicated hypertension, yes. But severe mental illnesses means cancer, malignancy, some kind of a tumor in the body, surgically operated, response not appropriate, otherwise the person is physically fine, healthy, appearance, but he is having that problem. So that is important that you have to assess it. Then substance abuse, history of alcohol use. So alcohol and other substances. Alcohol relatively less, but other substances relatively more. There are various studies quoting various figures. Some people say that in alcohol abuse, not use, it's the suicidality is high. Some people say, well, the possibility of committing suicide is more in marijuana. Some people say, but the data related to this, unfortunately, is not very solid or concrete that it can highlight. There is hordes of data, but we have to predict it from our own eyes as well. So that is unfortunately a tricky situation. And then the personality disorders or the traits. So all of these factors, shortly, briefly, in an exam situation, in 8 minutes time, you have to do the suicide risk assessment. 8 minutes, total of 8 minutes. You have to ask everything. आपका दिल करता है कभी ज़िंदगी ख़त्म करने का, अगर ख़त्म करने की कोशिश की तो कैसे की, माजी में ऐसा कब हुआ, आने वाले वक्तों में क्या प्लान है, कभी जब खुदकुशी की कोशिश की तो उस वक्त आपको कोई बीमारी थी, कोई आपको ज़िंदगी में कोई ऐसा मसला था जो आपके लिए बहुत ही बायस सबब परेशानी था, कभी आपको ऐसा लगा कि आप ने बंदूक उठाई, अपने मुंह में रखी और उसके बाद फिर आपने इरादा मुलतवी कर दिया. Now all of these questions, they are important in suicide risk assessment, and they will be asking one question from each of the domains that I have talked to you. We will come to it again. So areas to evaluate in suicide assessment. One is psychiatric illness. So any psychiatric illness, I mean any, is a risk to suicide. But the common suicide is usually seen in affective disorders, most commonly, so bipolar, major depressive disorder, more common. Even in mania, you have to assess the suicide risk because this is important. People say he's manic, so probably he won't commit suicide. The chances of committing suicide in mania are much higher than any other disorder mentioned here. So you have to assess the suicidality in mania, suicidality in depression, and this both domains are called affective disorder or bipolar disorders. Then there is history of substance abuse, alcohol abuse, schizophrenia, cluster B personality disorders. History is very important. So prior suicidal attempt, high risk. Aborted attempts or self-harm, high risk. Medical diagnosis, high risk. Family history of suicide, high risk. Mental illnesses in the family or him as a patient, then high risk. Individual strengths and vulnerability. Coping skills, personality traits, past responses to the stress, capacity for reality testing, tolerance of psychological pain are important. These days, people are talking about resilience, that Pakistani people have lots of resilience, so they are coming back from the COVID and they are fighting very well. I have a different viewpoint, so I'll be presenting very soon on that aspect as well. So if people are interested, then you can listen to that, the COVID-19 pandemic, the lessons we have learned. So as a professional, as a psychiatrist, I have a different viewpoint for every human behavior. And for me, these parameters are important. And to be a good psychiatrist, we have to see beyond the place where other people cannot see. So that is what is our goal and target. If you really want to help your patients, you have to see beyond the face of the person. So देख के कह देना, oh इसको schizophrenia है, oh इसको bipolar है, oh इसको depression है. I don't believe in that. I perceive in analysis, I perceive in other areas related to it, so that I'll be able to assess, right? And then manage. Okay? Can you hear me still? Anybody? Sorry, I muted. I hope it was not me. Okay. Can you hear me? मैंने चैट भी खोली हुई है और मैंने वो भी खोला बस मुझे ओके परफेक्ट ओके वील गो हैड सो यू हैव टू असेस अभी छोटा सा मैं एक ब्रेक ले लूँ ऐसे ब्रेक की बारी नहीं है लेकिन मैं फिर भी ब्रेक ले रहा हूँ वो उस्ताद मोमिन का एक शेर है तुम मेरे पास होते हो गोया जब कोई दूसरा नहीं होता मिर्ज़ा गालिब ने इस शेर के बारे में कहा कि मोमिन ये मेरा पूरा दीवान ले लो और ये शेर मुझे दे दो ये इतना डीप शेर है तुम मेरे पास होते हो गोया जब कोई दूसरा नहीं होता तो यूसुफी साहब से किसी ने पूछा कि जी ये उर्दू अदब में महबूब मुज़क्कर ही क्यों होता है मेरा महबूब आया मेरा महबूब गया बहारो फूल बरसाओ मेरा महबूब आया है सो ये महबूब मुज़क्कर क्यों होता है तो यूसुफी साहब ने उनको कहा कि जी ये शेर आप मुज़क्कर से मुअन्नस में करके पढ़ लें आपको समझ आ जाएगी कि उर्दू अदब में महबूब मुज़क्कर क्यों होता है सो तुम मेरे पास होते हो गोया जब कोई दूसरा नहीं होता अब अगर इसको मैं मुअन्नस कर लूँ तो तुम मेरे पास होती हो गोया जब कोई दूसरी नहीं होती सो सारा पैराडाइम ही चेंज हो जाता है सो एज अ साइकियाट्रिस्ट इस पैराडाइम को we have to assess clearly and properly. Now, determination of the risk. How do I assess that he is a risky person? Psychiatric examination, history, mental state examination, risk factors, जो पीछे जिनकी बात की, protective factors, family support, financially stable, no personality abnormality, no psychiatric morbidity in the past, things like that. Specific suicide inquiry, कभी खुदकशी करते वक्त खत लिखा, कभी किसी से बातचीत की कभी अपने ख्यालात का इजहार किया कभी हथियार हासिल करने की कोशिश की खुदकशी करने के लिए कभी नहर पे गए ये सोच के कि छलांग लगा दूं नाउ स्पेसिफिक सुसाइड इंक्वायरी सो यू हैव टू आस्क some of these questions and then modifiable risk factors like family support like medication antidepressant these are some of the modifiable risk factors and risk level low medium high we have to assess now risk factors as I mentioned earlier now we come to the demographics which can be the risk factors so male widowed divorced single increase with age and white Caucasian जापानीज़ में सुसाइड रेट सबसे हाई होता है क्यों कि वो अपनी इज्जत नफ्स को मजरू होते हुए नहीं देख सकते सो सेल्फ एस्टीम इज़ वेरी इंपॉर्टेंट फ्रॉम देम इट्स द मोस्ट ब्यूटिफुल नेशन इन द वर्ल्ड आई लव देम दे आर सो नाइस बट द सुसाइड रेट इज़ वेरी हाई psychosocial, lack of social support, unemployment, drop in socioeconomic status, firearm access, psychiatric morbidity, psychiatric illness, psychological dimension, hopelessness, psychic pain, anxiety, psychological turmoil, decreased self-esteem, बेइज्जती कर दी सारों के सामने मेरे बाप ने मुझे ये क्यों कहा सबके सामने कि तुम तो निकम्मे हो और सबके सामने मेरी बेइज्जती हो गई. Now only this factor can lead to some consequences, so we have to be careful. And fragile narcissism and perfectionism is also another issue. So if I am perfectionist, बेनज़ीर मुझे कहती है कि जी आप बड़े टाइम पे आ जाते हैं. So if I am perfectionist, then I have more tendency to commit suicide. That is important. So you have to, as a psychiatrist, remember this. Impulsivity, aggression, severe anxiety, panic attacks, agitation, intoxication, and prior suicide attempts. And above all, the cognition. People say that the dementia people cannot commit suicide. Dementia people can commit suicide. And it's unfortunately very high. The suicide rates are high in dementia. Suicide rates are high in intellectually compromise people as well. So we have to be careful. Sexual abuse, physical abuse, domestic violence. Now, बीवी बंदे से मार खा रही है, 10 साल से मार खा रही है, ठीक है. So there is a limit. I always give an example in my own language कि अगर लोहे की चादर नलके की टूटी के नीचे उसको रख दें और उसमें से सिर्फ एक एक कतरा उस लोहे की चादर पे गिरता रहे तो एक वक्त आएगा कि उस लोहे में सुराख हो जाएगा. So a drop by drop, this domestic violence, abuse, makes a hole in a thickest possible iron sheet as well. So you have to understand that, oh, she was very rigid, she was very fine, she was very strong because she was handling her husband very well. Maybe there was a point where she broke up. So that threshold point, that critical point is important in life, and it can happen to anyone. So it's not that me or you are just exempted from it. It can happen to anyone. So we have to be careful. Family history of suicide and mental illness and abuse. So protective factors. Children are the most important protective factors for a patient who is about to commit suicide. So if somebody is having children, and children, especially the young children, not the grown-up children, but the young children, like 6, 7, 8, 9, 10, or an infant, those people are having more protection towards suicide than people who are having not like that. Postpartum psychosis is an exception. So I'm not talking about the postpartum psychosis because that the parameters and the paradigm changes in postpartum psychosis. But other than that, yes, children at home is a protective factor. Pregnancy is protective factor. So if somebody is pregnant, she probably won't commit suicide not because of the fact that she don't want to, but the fetus in the mother's womb is a big protective factor. अल्लाह मियाँ ने उसको एक protection pregnancy की सूरत में दे दी होती है. Deterrent religious beliefs. So अगर मजहबी हूँ, अल्लाह पे यकीन है, आखिरत पे ईमान है और खुदकशी को हराम तस्वर करता हूँ, तो सुसाइड की अटैम्प्ट कम करूँगा. ये नहीं कि नहीं करूँगा, फिर भी हो सकती है, बट ये कुछ प्रोटेक्टिव फैक्टर्स हैं और ये मॉडिफाइबल हैं. दे कैन बी एनहांस्ड, दे कैन बी इंक्रीज, दे कैन बी मॉडिफाइड, दे कैन बी इम्प्रूव्ड, राइट? So reality testing. When I am a realistic kind of a person, I will think of 2 + 2 = 4. But if I am irrational, if I have a different opinion, like everybody now in Pakistan talks about politics, right? And they are very much strongly in favor or against somebody, which unfortunately bothers. How can you be so much after one person or the other person, right? You have to keep a balanced view. You can change or modify your loyalties. This is not that you should be just fixated to one idea or one party or one person. So that is reality testing. And we can check the reality with other parameters as well. Positive coping skills. So if I have an stress, I will definitely have certain way of coping with it. So what I will do is that I will maybe able, if I'm in financial crunch, what I will think, okay, fine, I have that property, I will sell that, I will gather the amount from there, and then I will utilize this to do this, and maybe things will be okay. So positive coping skills are helpful. They are protective factor. And positive social support, positive therapeutic relationship. Your relationship with the patient, how much good, empathetic and compliant relationship you are having with the patient. In these sessions ke dauran, there was one candidate who told me that she spent lots of time with the patient and still the patient was not well. Well, again, I have a different viewpoint. It's not the time that you spend with the patient. मैंने उसको भी mention किया था, अभी भी mention कर रहा हूँ. It's actually how you utilize that time. So वो कहते हैं ना, लव एट फर्स्ट साइट, एक दफ़ा देखने से मोहब्बत हो गई. तो अगर एक दफ़ा देखने से मोहब्बत होने वाला कॉन्सेप्ट सच्चा है तो मरीज़ से थोड़ी देर बात करने में भी आपकी रैपो स्टैब्लिश हो सकती है, आप अच्छा रिलेशनशिप बना सकते हैं. और अगर वो कॉन्सेप्ट बेकार है तो फिर यहाँ पे भी आप घंटों बैठे रहें मरीज़ के साथ, आपका एम्पैथेटिक रिलेशनशिप और लविंग रिलेशनशिप शायद ना बन पाए. सो एक बैरियर रहेगा आपके और पेशेंट के दरमियान. सो हैविंग अ गुड थेराप्यूटिक रिलेशन never means that you are spending too much time. Having a good therapeutic relation means that you click with each other. That is important, right? So, suicide risk in specific disorders like prior suicide attempts, there is 38%, eating disorders 23, bipolar 21. I won't be going into those figures, you can just look at them afterwards. Comorbidity. Whenever there are two psychiatric diagnoses or two physical diagnoses with a psychiatric morbidity, like a physical disorder, diabetic, and a psychiatric morbidity, major depressive disorder, the chances of committing suicide goes up. Access to diagnosis like personality disorder with the psychiatric morbidity, suicide rates goes up. So you just go through these figures and I am sure they will be helpful. Affective disorders and suicide. Suicide occurs in the course of illness. So it's not necessary that she is suffering from major depressive disorder for 20 years and now she committed suicide. So it can happen anytime. So you have to be careful. Risk for men is 4 times as higher as for women, except in bipolar disorder, where women are equally at risk. Now, I quoted this figure in this slide from one reference, but there are variable figures available. So, whatever the figures you quote in the exam situation, you should know the reference. So इस presentation के आखिर में कुछ references लिखे हैं. So those references are important. So when you are saying that suicide and substance abuse is 44%, then you should have a quote for it, a reference for it. Only then it will be valid. People may not agree with that study because of number of other reasons, but you have to know the reference for any disorder. High risk profile, previous suicide attempt, schizophrenia and suicide. Previous suicide attempts, significant depressive symptoms, first decade of illness, prior pre-morbid functioning, current substance abuse, poor current work and social functioning, and recent hospital discharge. Now, this is again very tricky. Schizophrenia people usually are not asked about the suicide. This is unfortunate, but this is unfortunately very bitter reality. The schizophrenia people can commit suicide and it's very tricky. So you have to be careful about schizophrenia. मैंने जो सबसे ज़्यादा रिस्क अपनी क्लिनिकल प्रैक्टिस में देखा वो उन स्किज़ोफ्रेनिया के पेशेंट्स में देखा जो स्किज़ोफ्रेनिया से रिकवर किए. So when I treat schizophrenia and patients do get better, and then when they start comparing themselves with the other people around them of the same age, वो फलां जगह निकल गया, उसकी शादी हो गई, उसके बच्चे हैं, वो नौकरी कर रहा है, मैं पीछे रह गया, मैं बीमार हो गया. Now that affective component, when it comes after the schizophrenia is treated, is a complicated situation where people do commit suicide a lot. Alcohol and substance abuse and suicide. Suicide occurs later in the course of the illness with communication of suicidal intent lasting several years. In completed suicides, men have higher rates of alcohol abuse, women have higher rates of drug abuse. Increased number of substance used rather than the type of the substance appears to be important. Most have comorbid psychiatric disorders. Females have borderline personality disorder. High risk profile, recent or impending interpersonal loss. Interpersonal loss means a broken relationship, comorbid depression, and things related to it. Personality disorders and suicide. So borderline personality disorder, high rate of suicide. Lifetime rate of suicide is 8.5%. With alcohol problems, it increases to 19%. And with alcohol problems and major depressive disorder and borderline personality disorder, suicide rate goes up to 40%. So मेरे पास जब borderline personality disorder का patient आता है, तो मैं उसको एक्चुअली साइकाइट्रिक कोमॉर्बिडिटी को असेस करके उसको प्रॉपरली मैनेज करने की कोशिश करता. In majority of the situation, if you treat the major psychiatric morbidity in these borderline personality people, lots of things improve. And then you can make them go into the therapeutic relationship in a psychotherapy and other relationships as well, which are therapeutic. So you can go ahead with it. Family history, genetics. Lots of studies are now done, as far as the genetics are concerned, and there is definitely, जब भी genetic पे question आएगा तो आपको चार चीज़ें मेंशन करनी। एक, सबसे पहली कि relatives में कितनी है, immediate family members में कितनी possibility है। Second, twin studies. Third, adoption studies. And fourth, modifiable risk factor, जो circumstantial genetic factors modify हो जाते हैं। So ये चार फैक्टर्स हमेशा जेनेटिक में याद रखें। अडॉप्शन स्टडीज़ का जिक्र करें, ट्विन स्टडीज़ का जिक्र करें, फैमिली हिस्ट्री का जिक्र करें, जेनेटिक्स क्लियर हो जाएगी। एंड मोस्टली सुसाइड इज़ हाई इफ़ एनी ऑफ दीज थिंग्स आर देयर। फैमिली साइकोपैथोलॉजी, अब्यूज़, वायलेंस, सेल्फ डिस्ट्रक्शन, एग्रेशन। हम सड़क पे चल रहे होते हैं पाकिस्तान में, गाड़ी लग जाती है तो, और 6 लोग साथ इकट्ठे हो जाते हैं और उसके बाद एक धमक दुनिया शुरू हो जाती है। मिलता किसी को कुछ नहीं है। कभी आज तक, इतने साल मैंने पाकिस्तान में 50 साल 55 साल गाड़ी चलाई, मुझे आज तक कभी भी कोई 1 रुपया किसी ने नहीं दिया गाड़ी का रिपेयर का। सो एक छोटा सा इंटरेस्टिंग सा मेरा अपना वाक्य मैं सुनाऊँ, आप लोग हैरान होंगे। सो वाई anger and aggression is so much on the roads? I don't know. So there is probably psychiatric morbidity there. I was driving on the canal from Garden Town to Services Hospital. That was my routine life for many years. So I was leaving Garden Town and I was on the canal going to Services Hospital. There was whole line of cars in front of me and the back of me. The front of the vehicle braked. I applied the brake as well. I stopped. I never touched it. The person behind me banged into me from the back. और उसके पीछे 5 गाड़ियां मजीद डस लग गई। मैं, क्योंकि मेरी अगली वाली गाड़ी को तो लगा ही नहीं था, तो वो निकल गया। मैं उतरा, मैंने देखा वो बम्पर वॉज डाउन। मैंने उसको देखा, मैंने उसको हिलाया, मैंने कहा टूट गया, ठीक है। मैं गाड़ी में बैठा, वो जो पीछे साहब थे, शरीफ आदमी बेचारा, ही स्टार्टेड अपोलोजाइजिंग, आई एम सॉरी, गलती हो गई, माफ़ी कर दें, मुझे ब्रेक नहीं लगी, लग गई गाड़ी। मैंने कहा कोई बात नहीं। मैं गाड़ी में बैठा, सुबह का टाइम था। मैंने ये दिल में सोचा, सुबह क्यों अपना मूड ख़राब करूं, जो लग गई, छोड़ो परे। गाड़ी में बैठा, चला गया। ही वॉज सो सरप्राइज्ड कि वो, मैं बैक मिरर में उसको देख रहा था कि वो 2-3 मिनट मुझे देखता ही रहा कि अच्छा ये चला गया, इसने बोला ही कुछ नहीं, इसने कहा ही कुछ नहीं। आई डोंट नो व्हाई people expect to have a fight when they bang a car on the road. I don't know why. It never happens here. Why? Because there is a rule, there is a law which specified, पीछे से किसी ने गाड़ी मारी है तो कसूर उसका है, आगे से गाड़ी आपने मारी है किसी को, कसूर आपका है। Simple rule of thumb, and it applies everywhere across the board. Why can't we do that? I don't know. I fail to understand. So, histories of childhood physical abuse, sexual abuse, neglect, पेरेंटल डिस्कॉर्ड। हम अक्सर ये बात करते हैं कि माँ बाप का रिलेशनशिप इज़ वेरी इंपॉर्टेंट फॉर दिस काइंड ऑफ अ सुसाइड रिस्क असेसमेंट। अगर माँ बाप में आपस में मुसलसल झगड़ा रहता है, पेरेंटल डिस्कॉर्ड, तो उसका डायरेक्ट इफेक्ट ही बच्चा है। और एक खिंच के रिलेशनशिप से बेहतर है कि वो रिलेशनशिप ना हो। अनफॉर्चुनेटली यहाँ रिश्ते टूटने की, डाइवोर्स की पाकिस्तान में वजह ये नहीं होती, और बहुत सारी वजूहात होती। सो इफ़ यू फील दैट देयर इज़ अ डिस्क्रिपेंसी इन द रिलेशनशिप, द पर्सनैलिटीज़ वोंट मैच एंड दे वोंट लास्ट लॉन्ग, then you should be honest about it, assessing जब marital counseling, assessing both the parties and giving your opinion. I don't know why we don't want to give your opinion. We are always trying to save our skin, and we don't want to say that this marriage cannot last. In my career, I unfortunately have told to people number of times कि जी ये शादी नहीं चलनी, ठीक है, इस पे मज़ीद अपने आप को वक्फ करने की ज़रूरत नहीं है। And I'm not saying it because of my judgment. I'm saying it because of my assessment, right? So if I'm assessing both the parties appropriately and I'm seeing those parameters, only then I should give my judgment. Not to give the judgment because मुझे ये intuition हुई है कि ये शादी नहीं चलेगी. No, I cannot do that, right? So we should be honest in giving our professional opinions, right? साइकोसोशल सिचुएशन, लाइफ स्ट्रेसेस, इसकी बात मैंने शुरू में की। लीगल प्रॉब्लम
कीजिएगा अपने आप को।
कौन अनम्यूट करेगा? मैं। Okay. I am unmute. Oh, sorry. I muted
Sir,
myself.
please unmute yourself.
जी 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 बिल्कुल 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 मैं कर रहा हूँ.
डॉक्टर नासिर आप अनम्यूट
बिल्कुल
कीजिएगा.
कर लिया कर लिया कर लिया. Sorry about that. Okay. So can you see me and hear me? Okay. Sorry. I muted myself. I'm sorry for that. So we should be honest in giving opinions, our opinion and professional opinion on the basis of the assessment that we do, right? So अगर मुझे किसी से मोहब्बत हो जाए तो मुझे ऑनेस्टली ओपिनियन दे देनी चाहिए कि मुझे उससे मोहब्बत हो गई है. वैसे आज तक हुई नहीं बीवी के अलावा, लेकिन बहरहाल स्टिल आई एम टेलिंग यू, बीइंग प्रोफेशनल वी शुड बी ऑनेस्ट, and being personal, of course, honesty is the policy, best policy. So identify stressors in context of personality, strength, vulnerabilities, illness, and support system. Psychological situation and firearms. I have already mentioned it, why this is a risky situation. Individual strengths. Meningier said psychoanalytical aspect of suicide. He said, believe that suicide should be understood through the interplay of three internal wishes: wishes to kill, wish to be killed, or wish to die. So when you are assessing suicide, you have to assess these three things: wish to kill, wish to be killed, and wish to die. All three domains are important when you are assessing suicide. And direct questions with the patient: suicidal attempts, first episode of suicidality, hopelessness, ambivalence, psychological pain, and history. Now, unfortunately, this pain thing, psychiatric morbidity and pain, it's a very, very important topic. And again, I believe that this is such an important topic that all of us should understand pain and psychiatric morbidity. I have a 2-3 very good presentations on it. हम ये सवाल नहीं पूछते, दर्द को हम फिजिकल डोमेन से रिलेट कर देते हैं. दैट साइकोलॉजिकल पेन or the pain because of some psychological issues, we absolutely decline it or deny it or don't ask them, which is important. So, components of suicidal ideation: intent, lethality, degree of ambivalence, intensity and frequency, rehearsal, presence or absence of suicidal note, and deterrents like family, bache, and other relationship is important. So, method, time, place, available means, and arranging sequence of events is important risk factor, and you have to assess them. And hopelessness, impulsivity, anxiety, and command hallucinations are psychiatric symptoms important to be assessed. And hopelessness has its own parameters. Impulsivity and aggression has its own parameters. So I won't go into the anxiety and command hallucinations, but I will definitely would like to say, when you assess the suicide risk, what needs to be done. The first and foremost thing in the whole of the situation is patient safety. So there is no compromise in it. If you really are a good psychiatrist, hello, can you hear me? I'm still there?
जी सर.
Okay,
Yes,
good.
sir.
मैं समझा शायद मैं फिर गायब हो गया. Okay, so सबसे ज़रूरी और इम्पॉर्टेंट फैक्टर पेशेंट की सेफ्टी है. अब पेशेंट की सेफ्टी के नीचे जो जो पैरामीटर्स हैं, उसको हॉस्पिटलाइज करना है, उसके इर्द गिर्द देयर शुड बी नो डेंजरस इक्विपमेंट अराउंड हिम विच कैन बी यूटिलाइज्ड टू कमिट सुसाइड. No medication or drugs should be accessible. People should be protected in a closed, monitored environment. If it's mild intensity, the family members should be, you should be able to tell it to the family to be careful. You should be able to see if they have put up a note or anything, and then be vigilant about it. No access to the firearms, nothing. And if there is a psychiatric morbidity, when you start the treatment, you have to be careful and monitor the patients relatively easier. ECT is still one of the best treatments that you can give to a suicidal patient, depending upon the intensity and severity. If it is acute and severe, ECT is best option. There is no doubt about it. But we always have to give a management plan in the exam, and management plan includes this. So management of a suicidal patient, one, patient safety, two, treatment plan, ये दवाई दूंगा ये दूंगा ये दूंगा, psychological treatment, ये करूंगा ये करूंगा ये करूंगा, जिसके बारे में we have talked about. Somatic treatment modalities, ECT, benzodiazepines, antidepressants, lithium and mood stabilizers, and clozapine. If necessary, then you have to try that. Psychotherapeutic intervention, widely viewed as helpful for suicidal patients. Evidence is limited, but that is the true and effective treatment. Provide education to the patient and the family. Monitor psychiatric status in response to the treatment and reassess safety and suicidal risk. When you feel that the patient is safe, only then he should be allowed to go. Otherwise, and the compliance to the treatment is the key. So they should keep on taking the treatment for a longer period of time, till the time both of you and the patient should be able to agree on certain parameters. Yes, this is the good time to reduce it or discontinue it. Otherwise, I think you should continue with it. Now, this is the most important slide and the crux of the matter of the whole presentation. Sad persons. Sad persons is the key. Remember this word, sad persons. Sex, men 3 times higher than women. Age, greater risk among 19 years old or younger, 45 years old or older. D, depressed, 30 times more than non-depressed. P, previous attempts, 64 times more than general population. E, ethanol, alcohol abuse, 15% higher than the normal people. Then R, rational thinking loss, psychosis, again higher chances. S, social support lacking. O, organized plan, having method in mind and creates more risk. N, no spouse, single, widowed. And S, sickness, mental and physical, both, or any terminal illness. So the sad persons is the key to remember most important factors in the suicide, and you have to ask everything. He's a male who is 46 years of age. He is suffering from major depressive disorder. There are 3 previous attempts. There is a history of alcohol abuse, history of psychosis, bipolar mania or something. Social support is lacking. He lives all alone and supported by some of the family members who come and go to his place. He has attempted in the past twice where he was unsuccessful, no wife, no children, and he is suffering from complicated diabetes. The risk is 90%. There is a scoring for sad persons which is available on the net. So go back. Sad persons, remember that. Sad persons scoring sheet, take it up. If this is 50%, even 50%, 50% is not a big proportion. If the sad person score is 50%, he is suicidal and you have to hospitalize him. And if the sad person score is less than 30% or 40%, then he can be managed at home. So you have to be careful about assessing this. ECT, benzodiazepine, antidepressant, lithium, antipsychotics, then the psychotherapy. We talked about that. मैंने 5 therapies जो बताई थी वही यहाँ पे भी apply करें. Or suicidal contracts. Now this is important. The suicidal contract. Oh, it's a long presentation. I don't want to go there. It's a depression as well. So when I was telling you about the psychotherapies, I was telling you what to do about it. So that is important. वही psychotherapies जिनका जिक्र मैंने पहले किया हुआ है, उन्हीं psychotherapies का जिक्र यहाँ पे करें. They will work well. Any questions so far? Just let me know. Okay, there is a question. So what were you telling about COVID-19 resilience with respect to... Okay, I will present it soon so you will know. जी वालेकुम अस्सलाम, बोलें.
Sir, please correct me if I'm wrong. At the start of the presentation, when you were telling about the risk factors, you said that narcissistic personality disorder is also a risk factor.
Yeah, yes, exactly. When do you say narcissistic personality disorder, what do you mean by that? Do you know that? So the narcissistic
Yes.
personality, जिनमें मैं बड़ी होती है ना, हमारे पाकिस्तानियों
Yes,
में
sir.
बहुत सारों में मैं बड़ी होती है. They are all narcissistic actually. Now, whether you want to categorize them into personality disorders or no, I don't know. But जिस शख्स में भी मैं बहुत होगी, मैंने ये किया, मैंने वो किया, मैंने इस तरह किया, मैंने वो पहाड़ गिरा दिए, मैंने बम चला दिए. Now, जहाँ भी मैं होगी, that you have to, as a professional, you have to assess the narcissistic personality disorder. And if it is there, then of course, it's a higher risk factor.
Sir, in the Journal of Psychiatric Research, it is a USA-based journal. There was a research published in year 2018 on narcissistic personality disorder and suicide attempt. It said that the low impulsivity and relatively rigid personality of narcissistic personality disorder is directly proportional to non-fatal low lethality suicide attempt. I was slightly confused that.
So, Dr. Saab, the important thing that mentioned in the paper is that there are two things which you quoted yourself. So, if those two traits are prominent, the risk for the suicide is less in narcissistic. But if other 5 parameters are there, there is a strong tendency of committing a suicide. So they were just only 2 parameters which were correlated with the suicidal intent or suicidal attempt, not whole of the narcissistic personality disorder. And again, this is just one paper. I always said that you will have definitely hordes of weightage of papers having both sides, right? So this is this is this. As I've told you about the male and female gender. You go to the suicide rates across the globe, the figures are variable as far as various studies are concerned. But this never means they are wrong. This means that this is another domain to assess and to go forward to. So, narcissistic personality disorder, yes, high possibility. मैंने एक बात की जिसमें मैं बहुत होगी, जिसमें मैं बहुत होगी उसकी सेल्फ एस्टीम अगर लो हो गई ना तो मर जाएगा, वो सुसाइड कमिट कर लेगा. But what you are saying is that is a different story. So yes, and precisely, unfortunately, we never see the whole bookish picture of any disorder in a single patient. There is always a mixture of it. So that's the reason, unfortunately, in psychiatry and assessing suicidality and collecting data on it is quite a difficult project. बट हमारे पाकिस्तान में बहुत सारे लोगों ने इस पे काम किया है. अब्दुल वहाब यूसुफ ज़ई साहब ने बहुत काम किया है, मुराद मूसा साहब ने बहुत काम किया है सुसाइड पे, और भी लोग होंगे, बट मुझे इन दोनों का ज़्यादा अंदाज़ा है कि इन दोनों ने सुसाइड पे बहुत काम किया हुआ है. एंड इट्स अ गुड वर्क एक्चुअली. सो इफ़ यू गो थ्रू देम then you will be able to see that hordes of research papers have been conducted. Right?